the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. We're continuing our discussion with Dr. Hall on pediatric overuse injuries in sports medicine. Welcome back, Dr. Hall.
Thank you. Thanks for having me.
We are on the home stretch. We're going to jump ahead to upper extremities. Dr. Hall, can you talk about gymnast wrist? In just a quick part, there was actually a published case study in the PA journal called JAPA recently, and I did a podcast with the author, the whole podcast on gymnast wrist. So I was hoping you could review this for our listeners about what it is, the presentation, and how you manage it.
Yeah, so gymnast wrist, in effect, is a stress fracture of the distal radius. It's usually a Salter-Harris 1 stress fracture of the distal radius. Actual name is distal radius epiphysiolysis, but it is a repetitive impact injury to the wrist. Does not need to be in just gymnast. I would say competitive cheer is just as likely to have this diagnosis as is gymnast. And I think that it can be quite not challenging to make the diagnosis, but there can be some other diagnoses on the differential that can kind of blur the picture. So, for example, you may think, oh, well, is this a ganglion cyst that I can't see? Or is this just extensor tendonitis? And I think those can certainly make the diagnosis more difficult, but you want to have that history, right? So if the person is a, let's say, baseball or softball player, the chances that they have gymnast wrists are very low. But you need to have the history of the impact. You need to have the history of it being repetitive and that there's no clear trauma, just repetitive impact. So that's the first thing. And then on exam, you really want to make sure that you can get your finger on the bone. And I know this is kind of like nitpicking, but you can get those extensor tendons on the back of the wrist, on the dorsal aspect of the wrist. You want to just slide off of the side of those and just get directly on the bone. And again, you want the patient to say, yep, that's the spot. So I say that phrase almost every visit. Is that the spot? My kids love Harry Potter. And so I ask them, if I had a magic wand and I could take your pain away, where would I touch that wand to? And then that's the spot. And so usually if it's on the bone, I feel more comfortable with calling it gymnast wrist. If you're a little bit more distal into kind of like the soft area of the actual wrist joint, I hesitate a little bit and wonder, okay, is this more tendonitis? And then my management, I try to be thoughtful. So I try to allow them to do a wrist brace for 4 weeks. But I have partners that are like, nope, gymnasts don't listen. They're going in a cast. And I've had that same situation where the family's like, yeah, they took the brace off in a week and just kind of toughed it out. So I will give the family an option of a cast versus a brace, but usually I'm doing about a 4-week shutdown. In the meantime, why I like to do the braces, I can still have them working on forearm strength. I can have them working on shoulder stability. Remember, the opposite of walking. So they're putting their hands on the ground and they're using their shoulder as kind of like their base of support. So sometimes if you can improve the base of support, you can improve the pressure that's put through the wrist. There is some newer strategies coming out with trying to just look by ultrasound to see if you can see changes, and I haven't quite perfected that. And then this is definitely a case where I think it is reasonable, even for the expert, to get bilateral films, because sometimes you're talking about a difference of 1 to 2 millimeters if it's only unilateral. And so I think that can be useful information. But that's how I'll approach gymnast wrist. And then again, focusing on the functional deficits in the upper extremity that might have led to this.
And I'll just throw in my little tidbit that gymnasts are tough. And if you see a gymnast that is complaining of pain and they actually came in to see you, there most likely is going to be something wrong. So make sure you take a good look at that. Dr. Hall, we talked about elbows. You had talked about, I think, little leaguer's elbow and medial epicondylitis. Well, is there a difference between those two things? And then how would you manage each one?
So I would really consider them the same, in my opinion. I would consider little leaguer's elbow medial epicondylitis as far as the medial epicondyle growth plate. How I work through this case is I've got to get the history. I've got to get a good throwing history. How many teams are they on? Do they play catcher? Do they play pitcher? Do they play both? Does it hurt with batting? Those are key features. And then just that, hey, finding the spot. Okay, just as you mentioned, if you can't find the spot to squeeze on, then you can't really make the diagnosis. So if I get right on that medial epicondyle and that lights them up, then I feel very comfortable with calling it medial epicondylitis. Just as a side note, if an athlete, a pediatric athlete, does not have full range of motion of their elbow and you're considering a overuse injury, I would get an x-ray and even consider an MRI. Athletes with normal elbows should have full range of motion of the elbow. What I'm getting at is being thoughtful about like an osteochondritis dissecans in the elbow. If someone presents just with like, I can't straighten my elbow all the way, that is not typical of a medial epicondylitis. So once I identify that there's pain over that medial epicondyle, I do just slip down maybe half a centimeter to press over that ulnar collateral ligament. Generally, that's not going to be painful, but every baseball player that you'll ever see, that's all they want to know is if they have an ulnar collateral ligament. I mean, the kids can be 9, and when I say, well, I don't think it's coming from your UCL, like the family just is like, oh, thank goodness, you're like, well, we didn't really, it wasn't likely going to be that, but so I think that is quite helpful, just the history and exam there. And then I don't play around with these. I just say, hey, we're going to shut you down for throwing for 6 weeks. I think, I could be convinced into maybe 4 weeks, but usually shut you down for 6 weeks. I get them in PT right away, working on lower extremity strength. If you just stand and do a pitching motion from the mound, you realize that a lot of the velocity is coming from your lower legs and pushing off of the mound. And so we get kids who have a very poor single leg squat, single leg stability, and then wonder why their shoulder and elbow hurts. And that's really the focus in the PT on the early stages. Not so much shoulder programs in the early stages, but leg, hip, and gluteal strengthening is what I focus on, even though the issue is with the elbow. What I tell the families is the elbow is the victim of a poor core, glute, hamstring strength, and they see it a little bit better in that way. I will say there can be these little irregularities to the medial epicondyle that can look like avulsion fractures. So I think just using your history, they tend to be just more like tug lesions from the tendon or muscular attachment. But using your history, if there was no pop, no fluid, no swelling, then that's probably unlikely to be an avulsion, even if the report is stating such. And I don't mean medial epicondyle avulsion itself, like a avulsion to the growth plate is a subtlety. And then at about the 4 to 6 week mark, I will start that return to throwing program. I do allow them to bat as well if they don't have any pain. And then I also allow them to catch, physically catch a ball. So if they want to take grounders and just scoop the ball and then just drop it with the other hand, I think that's okay. We have to remember mental health in these athletes, and telling someone who is a teenager and thinks that sports is the only thing that they're good at and is their whole identity, telling them to be out of sports for 6 weeks or 8 weeks seems very simple to us as adults, but it can be quite dramatic. And so finding ways to keep them active, to keep them with the team and in the game, I think is just as critical at getting the pain resolved as well.
A quick question on that. Do you have any physical therapists that can work with the patients on throwing mechanics?
Yes, there's several therapists, at least in our community. And I think it gets at a bigger question of communication with the folks in your community. I realize everyone is busy, but it does not hurt to call a therapy office and say, hey, you're seeing so-and-so, just wanted to give you a heads up, or asking around to say, hey, are there people who are more familiar with baseball? Because the outcomes do change if you have people that are more familiar with the sport. They can talk the language with the kids feel more comfortable. So yes, I think there are definitely expertise within the physical therapy community who can handle some sports better than others or handle kids better than others. And I think that is really important. But it starts with you as the medical provider to say, how can I connect with these people? And just picking up the phone sometimes and learning a name and learning a group to say, oh yeah, I like my throwers to go to this woman because she is very familiar. And it helps also prime the athlete to say, oh, okay, I'm going to someone who's very familiar. I think, as you can see, I try to take advantage of any psychological advantage that I can in these young kids.
Absolutely. Whatever you can do to get them better. Listeners, stay tuned for next week when we continue our discussion of overuse injuries in pediatrics with Dr. Randon Hall. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.